Hello, every year we will learn about the appendix and rectum mammendix. Position of the appendix. The position of the appendix mainly depends on the position of the cecum. The appendix is usually located in the right iliac fossa together with the cecum. In rare cases, ectopic appendix may occur with changes in the cecum's position, such as high possession, low possession, or left lower abdominal appendix. Although the positional relationship between the root of the appendix and the cecum is relatively fixed, the body and apex of the appendix have high mobility, so the appendix has multiple positional relationships with the ileocecal region in the right iliac fossa, such as subileal, retrocecal, subcecal, preleal, and retroleal positions. In Chinese people, the appendix is most commonly found in the subileal and retrocecal positions. Due to significant variations in the appendix position and adjacent structures, appendicitis may present with different symptoms and signs, which increases the complexity of diagnosing and treating appendicitis. The appendix position varies greatly, making it sometimes difficult to locate during surgery since the three colic bands converge at the root of the appendix. Tracing downward along the colic bands is a reliable method to locate the appendix.
The appendix is a thin tubular organ extending outward from the posteromedial wall of the lower end of the cecum. It is also called the vermiform appendix because its shape resembles an earthworm. Its length varies among individuals, generally about 5 to 7 centimeters, occasionally up to 20 centimeters or as short as 1 centimeter. The surface projection of the appendix root is usually at the intersection of the line connecting the right anterior superior iliac spine and the umbilicus, at the outer one-third of the line, known as McBurney point. Sometimes it is also indicated by Lanz point, i.e., the intersection at the right middle one-third of the line connecting the left and right anterior superior iliac spines. Due to frequent variations in the appendix's position, the exact surface projection is not very important for diagnosing appendicitis. A localized tenderness point in the right lower abdomen is more diagnostically significant. Congenital absence of the appendix is extremely rare. The root of the appendix is relatively fixed, most open into the cecum about 2 centimeters postero-inferior to the ileocecal orifice. This opening is called the appendiceal orifice. There is an indistinct crescent-shaped mucosal fold at the lower edge of the orifice, called the appendiceal valve, which prevents fecal masses or foreign bodies from falling into the appendix lumen. The apex of the appendix is a free blind end with high mobility, so the appendix's position is not fixed. The diameter of the adult appendix is mostly 0.5 to 1 centimeter. The lumen is narrow and has poor emptying, making it prone to obstructive appendicitis. The mesoappendix is triangular or fan-shaped, containing blood vessels, nerves, lymphatic vessels, and lymph nodes. Since the free edge of the mesoappendix is shorter than the appendix itself, the appendix bends to varying degrees, e.g., hook-shaped, S-shaped, or curled, which are morphological factors that predispose it to inflammation. Rectum. Position of the rectum. The rectum is a segment of the digestive tract located in the lower part of the pelvic cavity, with a total length of 10 to 14 centimeters. It originates from the sigmoid colon anterior to the third sacral vertebra, descends along the anterior surface of the sacrum and coccyx, passes through the pelvic diaphragm, and transitions into the anal canal. Flexures of the rectum. The rectum is not straight. It forms two obvious flexures in the sagittal plane, the sacral flexure of the rectum and the perineal flexure of the rectum. The sacral flexure of the rectum is an arcuate flexure of the upper rectum. descending along the pelvic surface of the sacrum and cocky that protrudes posteriorly, 7 to 9 centimeters from the anus. The perineal flexure of the rectum is an arcuate flexure of the terminal rectum, curving around the coccyx tip and turning postero-inferiorly, that protrudes anteriorly, 3 to 5 centimeters from the anus. There are also 3 lateral flexures in the coronal plane, but they are not constant. The larger middle one usually protrudes to the left, and the upper and lower ones protrude to the right. During clinical proctoscopy or sigmoidoscopy, these flexures should be noted to avoid intestinal wall injury. Structures of the rectum. Transverse rectal folds. There are 3 transverse rectal folds in the rectal wall, composed of mucosa and circular muscle, which function to block the downward movement of feces. The upper transverse fold, near the junction of the rectum and sigmoid colon, located on the left wall of the rectum, about 11 centimeters from the anus. Occasionally, it encircles the intestinal lumen, causing varying degrees of stenosis. The middle transverse fold, large, prominent, and constant in position, usually located on the right anterior wall of the rectum slightly above the rectal ampulla, about 7 centimeters from the anus, at the level of the peritoneal reflection on the anterior rectal wall. Therefore, during sigmoidoscopy, it is often used as a landmark to determine the positional relationship between tumors and the peritoneal cavity. The lower transverse fold, mostly located on the left wall of the rectum, about 5 to 6 centimeters from the anus to rectal ampulla. The rectal ampulla is the dilated lower part of the rectal lumen. 4. Anal canal. 1. Position and function of the anal canal. The anal canal is about 3 to 4 centimeters long. Its upper end connects to the rectum at the level of the pelvic diaphragm, and its lower end terminates at the anus. It is surrounded by the anal sphincters, which are normally contracted to control defecation. 2 mucosal structures of the anal canal. Anal columns. Anal columns, 6 to 10 longitudinal mucosal folds on the inner surface of the anal canal, more prominent in children and less obvious in adults, containing blood vessels and longitudinal muscles. Anal valves, crescent-shaped mucosal folds connecting the lower ends of adjacent anal columns. Anal sinuses, upward opening recesses formed between each anal valve and the lower ends of 2 adjacent anal columns, 3 to 5 millimeters deep, with openings of anal glands at the bottom. Fecal debris often accumulates in the sinuses, making them prone to infection, anal sinusitis. Anorectal line, the line connecting the upper ends of the anal columns, serving as the boundary between the rectum and anal canal. Dentate line. Dentate line, anal cutaneous line, a serrated circular line connecting the lower ends of the anal columns and the edges of the anal valves. The intestinal segments above and below the dentate line differ in arterial supply, venous return, lymphatic drainage, and nerve innervation, which is of great clinical significance. Pecten. Pecten, hemorrhoidal ring, a circular region about 1 centimeter wide below the dentate line, smooth in surface, with a superficial blue color due to the underlying venous plexus. White line. White line, an indistinct circular line at the lower edge of the pecten, located between the subcutaneous part of the external anal sphincter and the lower edge of the internal anal sphincter. A circular shallow groove, intersphincteric groove, can be palpated here during digital rectal examination. 3. Anus. The anus is the lower orifice of the anal canal, a longitudinal fissure with an anteroposterior diameter of about 2 to 3 centimeters. The surrounding skin is pigmented, dark brown. Adult males have stiff hair around the anus, along with sweat glands and abundant sebaceous glands. In this class, we have learned about the rectum and anal canal. In the next class, we will start a new chapter.